Welcome everybody, and thank you very much for your interest in our webinar tonight. I'm Wendy Gerhardt. I work with Migraine Canada and happy to be hosting this webinar this evening with Dr. Kingston, who I will introduce in a moment. I want to start off by thanking our sponsors. Without our industry support, we wouldn't be able to bring a lot of our programs and events to you. So thank you very much to our sponsors. Today's agenda, I'm just going to give a very brief overview of Migraine Canada for those of you who are not familiar with us. Dr. Kingston has graciously agreed to be your host presentation, our keynote speaker tonight on cluster. And you have an opportunity to ask your questions and get some answers from Dr. Kingston. And we ask that you put your questions just into the Q&A chat, and we'll hold them until the end, and then we'll work through those. So for those of you who aren't familiar with Migraine Canada, we are a national organization supporting all Canadians living with migraine and headache disorders. We are federally registered as a not-for-profit corporation. We are young. The organization has only been in existence for about 2 years, which totally shocked me coming from the pharmaceutical industry, where I've been working with lots of organizations who have been around for 25 or 30 years. So we're very young. We're growing quickly, and we're really here to support the community. Our board is comprised of volunteers. We have some healthcare professionals on our board, and we also have a significant number of people who are patients or live with migraine themselves. We have an executive director, and we run on the help of volunteers. And so that's who we are. Our mission and vision are very simple. Our vision is that Canadians living with migraine and headaches are diagnosed, treated, and supported so the quality of life is optimized. And our mission is really to improve the lives of Canadians with migraine and other headache disorders through awareness, support, education, advocacy, and research. We have 5 strategic pillars, and I won't go into detail. Very, very common in not-for-profit organizations: awareness, education, support, advocacy, and research. And those are all, I just read them through in our mission as well. A call to action from you tonight is to sign our petition and join our growing community. Without your voice and your support, we need to have a good backing and a strong community so that I can go out and advocate on your behalf. So I encourage you to sign the petition and join the community. And just a little bit of housekeeping. We provide information, not medical advice. The information that you will be presented this evening and discussed may not apply to your own medical situation. And we ask that you discuss your medical treatments with your own healthcare provider who knows your medical history. And with that, I'm going to turn it over to Dr. Kingston after I do a brief bio from him. He was born in Moncton, New Brunswick. His neurology training was at the University of Toronto. He received his headache medicine fellowship at the Mayo Clinic in Arizona, and he's currently working as a headache neurologist at Sunnybrook Health Sciences Center and Women's College Hospital in Toronto. His major interests include cluster headache and headache in pregnancy, and he runs the only dedicated headache in pregnancy clinic in Canada. And with that, I will turn it over to you, Dr. Kingston.
All right. Well, thanks so much for having me. I get to talk about one of my favorite topics today, which is really great. And it was exciting to see so many people that were interested in hearing about it. I know there's a wide variety of folks out there listening, from healthcare providers to pharma people to patients to family members. So I've done my best to try to make the language suitable for everyone. But of course, if there's something I've said that hasn't made sense, just let me know afterwards, and I'll try to clarify as best I can. The way that I'm framing this is to kind of give everybody an overview of exactly what cluster headache is, why it's important. And I think one of the things that I get asked often is, why aren't there more treatments for this? And why do so few people know about it? And I hope to shed a little bit of light on why that's the case and why it can be so problematic. There we go. So I have some, speaking disclosures that I always share before every slide. None of them are terribly relevant to today, but in the interest of transparency, here they are. So what is cluster headache? So we look at cluster headache as being what we call a primary headache disorder. And when we use the word primary headache disorder, what that really means is we don't have a known underlying cause that's causing the symptoms. So, for example, the most common primary headache disorder that we would see in clinical practice would be migraine. It doesn't mean that there isn't some kind of generator for migraine. It means that if we do a scan or if we do blood work, we're not seeing an underlying cause that's reversible. So cluster headache is another primary headache disorder. The way that we characterize and what kind of symptoms we see, and really the way that we make a diagnosis of cluster headache is based on the symptoms that one has, is it's a syndrome of headaches that are what we call side-locked. So for example, you may hear the word unilateral, which means one-sided, and migraine can be one-sided too, but it will often change sides. With cluster headache and related disorders, we often see side-locked headache, meaning that it's always on one side and does not change sides between attacks. Usually, this is in accompaniment with what we call autonomic features or autonomic symptoms. When I use the word autonomic, that really refers to the part of the nervous system that is responsible for automatic functions that we don't have conscious control over. And I'll talk about what exactly those symptoms are in a moment. I think it's important that cluster headache has had many names throughout the ages, and a lot of them are antiquated now, but one of the names that gets thrown around a lot is suicide headaches. And I'll explain as to why that is as we go forward a little bit. The way that we characterize headache disorders in general, and cluster headache is no different, is by calling them either episodic or chronic. And I think one thing that's important to note is that the way that we use the word chronic when it relates to headache disorders is a little different than how we use it to relate to other medical problems. Episodic, in this case, means headaches that come for a period of time and then go away for a while and then come back. Whereas chronic means that they last for a long time without any significant period of reprieve. And I'll show you exactly what that cutoff is at the moment. Interestingly, if we compare it with migraine, it's a little more common for us to be fooled in that there actually may be something underlying that causes cluster headache, but it's still the minority of the cases. And usually there is some features that are a little bit different in people who have something else causing it that I'll explore a little bit with you guys. I promise I'm not going to go over this nightmare of a slide, but I have it here really to show you what the difference is and how we make the diagnosis. So basically, the way that we characterize headaches in this class of headache, which we call trigeminal autonomic cephalalgias, or TACs, of which cluster is by far the most common type. So the way that we describe it are headaches that are one-sided, that last from 15 minutes to 180 minutes if they're untreated. So if someone doesn't take medicine, how long will the headache go for? That's the cutoff that we typically use. And then it should be accompanied with what I mentioned as autonomic features. And if we actually look at what that means, conjunctival injection means redness of the eye. And usually that would be on the same side as the headache. That can be also accompanied by lacrimation, which means watering of the eye on the same side. We can also see nasal congestion on the same side as the headache, and sometimes even forehead sweating. And ptosis and meiosis refers to changes in the sizes of the pupil on the same side of the headache when the headache is active. And usually we also look at the frequency by which those headaches happen. So not only how long does each individual headache last for, how often is it happening? And we look at that as being anywhere from once every other day to upwards of 8 times per day. And if you contrast that to people who have migraine, for example, typically there would be one prolonged headache during the day. Of course, there's exceptions to every rule, and perhaps the headache can be treated and then come back with migraine, but it is quite a different disorder for the most part. And here's how we make that distinction between episodic and chronic, as I mentioned before. So an episodic cluster headache means that there is a period of time where there is at least 3 months between headache episodes. And chronic means there is no period of 3 months between episodes of headache. So thankfully, most patients with cluster headache have what we call episodic cluster headache, because the chronic cluster headache is a much more difficult disorder to treat, unfortunately, and a very difficult one for people to experience. So as I mentioned, these autonomic symptoms we see can be paramount at making the diagnosis. And the watery eye is probably the most common. About 75% of all people with cluster headache do have a watery eye on one side when they get this headache. And then the red eye is the second most common, followed by the nasal congestion. And the word Horner syndrome refers to a little bit of a droopy eyelid, a change in the pupil size, and potentially a change in the sweating that all happens at the same time. And that can sometimes happen even between attacks for people who have really, really frequent headache attacks. So interestingly, if you think about, and I'm sure, migraine, for example, is a very common disorder that I would imagine every single person on here knows somebody with migraine. And here you hear someone with migraine and what they want to do is go lay in bed, tell everyone to leave them alone so that they can get some rest and feel better. Contrast that to people with cluster headache who feel very agitated and often restless during an attack. If you actually do a screen of people who have cluster headache, only about 3% of people with a diagnosed cluster headache feel like they can actually sit still during an attack. So people will rock back and forth, they'll pace, sometimes they'll bang their head against the wall. I've heard people jump into a frozen pool before, jump into the snow. All of these things really do happen. I like to include this picture because it was at a headache conference that I attended a couple years ago. From these actors were depicting artist depictions of what people experience during a cluster headache. And I think that this really hits home in that many people who have cluster headache will describe a sense that there's almost a foreign body in their eye on the same side as the headache episode. So this is very interesting. But there is some other features with cluster headache that make it a little bit different. And personally, what I think makes it one of the more interesting problems that I see, in that there is what we call a circadian periodicity. And what that means is there seems to be a very clear effect of the time of day. So sometimes people who have cluster headache can actually set their watch by the time they're going to get their cluster headache. And they'll know every time on this day I'm going to get it, at this time I'm going to get it. And the same thing goes with what we call a circannual periodicity. And what that means is that there's a seasonal predilection, meaning there may be one season where their headaches are very, very, very active, and then they may go away for half the year and then come back. And I'll show you a little bit of data on some surveys that were taken worldwide to demonstrate this. When I say migrainous features, if you hear about someone with migraine, you may hear that they're sensitive to lights or sounds, or they feel nauseous. Those are less common in people with cluster headache, but sometimes when you do see them, they, for example, may be sensitive to light, but only in the eye that's affected by the cluster headache, only on that same side. So sometimes that can be a reason why things get a little bit misconstrued in terms of a diagnosis. So this circadian periodicity, that like the time of day effect that I mentioned, can actually be pretty striking. And I'll show you exactly why that is, I think, in the next slide. But for what it's worth, there does appear to be an association in terms of genes that people carry for cluster headache that also have some commonality with people who have genes for certain sleep disorders, although that association is not entirely fleshed out and is a source of what we need to study a little bit more to fully flesh out. So interestingly, in 2011, there was a study that was done interviewing people sort of around the world. And no matter where people lived, no matter what time zone they were in, the single most common time of day to have a cluster headache attack was at about 2 a.m. So very, very interesting. What also can be striking about this time of day effect is that it can make people afraid to go to sleep. So people can then start to develop sleep disorders because they know, oh my God, I'm going to wake up at 2 a.m. with this horrible headache, not be able to sleep, pace around the room until it goes away. And it's really just excruciating. And this can lead to anxiety about going to sleep, which is something we call, it's a long nonsense word, but it's cephalalgia, which means fear of getting headache, essentially. For whatever reason, the seasons seem to be a little bit different in different countries. When things are most active, that may have an effect of sunlight, but we're not completely sure about that. But for what it's worth, in North America, spring and fall, cluster headache seems to be a little bit more active compared with summer and winter. Some people will cycle differently. Some people with episodic cluster headache will notice a very clear, every fall, every spring. Some people will be every fall. Some people, it's only every 2 years. And often people will follow the same trajectory, but this is a disorder that people have for many, 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 many years, and its pattern can change a little bit over time as someone ages. So this is another sort of graph of the most common time of year people will develop symptoms. And this was in North America. And again, it very clearly shows peaks sort of in October and then again in March and April. So the other things that I think are really important that I'm sure there's at least a few people on here that can relate to this is that there's a big delay in diagnosis. So the average time from the onset to diagnosis is 5 years. And when people first go to the doctor with these symptoms, only about 20% actually receive the correct diagnosis, but the first time they go to the doctor. And I think this can be important just because of the severity of these headaches. You know, I don't have a slide relating to this in this particular talk, but if you, for example, have one person who has experienced kidney stones, childbirth, and cluster headache, and they've experienced all of them, cluster headache is always rated as the most painful, and it's often referred to as the most painful condition known to human beings. And that's why it's so important. And for what it's worth, about 55% of all people with cluster headache have experienced some suicidal thoughts during these headaches. So it's nothing to shake a stick about, and it's a really important thing to get treated. For what it's worth, we know that alcohol can be a trigger for people with cluster headache, but interestingly, it seems to only be a trigger when someone is in that susceptibility period. So let's say someone has cluster headache and they tend to only really cycle in, let's say, the spring. If they have a beer in the spring, they may get a headache. But if they have a beer in October, no problem, doesn't cause a headache. So it's a very interesting disorder from that. And for what it's worth, we know that there's also certain alcohols that tend to be more triggering than others. And for whatever reason, we've noticed that beer seems to be a little bit more triggering than other types of alcohol. About 75% of individual attacks are less than 60 minutes. So sometimes they can be brief, and that can make it really tricky to treat them, which is something I'll touch on in just a moment. There is some people who will notice during one cluster period. So that is to say, while it's active, and then you compare it to the next time they develop it, where it can switch sides. But that's a very, very small amount of people who experience cluster headaches. So that's the minority of people. So interestingly, and I like to share this statistic because I don't know really what it says about how well we're recognizing this, but I still think it's an interesting thing. So for example, if I'm teaching a group of residents, one question that I'll often ask them is, who here has seen a case of multiple sclerosis? Who here has seen a case of Parkinson's disease? Inevitably, everyone in the audience will raise their hand for both of those questions. But if I ask the same question and say, how many people here have seen a case of cluster headache? You'd be surprised how few have actually seen them. And I know there are residents who go through their entire neurology residency without actually having seen a case of cluster headache because it's not being recognized enough, which is unfortunate because it occurs at the same prevalence in our population as multiple sclerosis and Parkinson's disease. So it's not that it's not there. It's that we're not either we're not seeing it or we're not recognizing it. And I think there's a couple of reasons for that I'm going to touch on. For what it's worth, it rarely occurs in the pediatric population. So it's rare for it to start before age 18, but it has been seen. So there are reports of that. And again, it's also pretty rare for it to occur in older age. And when we see it occur in an older age, that's when we really need to think about looking and going a little deeper, looking to make sure we're not missing something else that could be causing the symptoms. Because I want you all to think about what it's like when you go to the doctor for a moment. So let's pretend that you have seen your family doctor, you've just developed this horrifying headache, and they say, okay, I'm not sure what this is. I'm going to send you to, let's say, a neurologist. Okay. Let's say on a good day, you have a wait time of a couple of months to see a neurologist, at the best of times. By the time you get to the neurologist, your headaches may be gone. And maybe you'll say, well, geez, it's gone. Why would I even bother keeping my appointment? And I think a lot of the times that is what happens. And because that happens, or because when you get to the neurologist, you're no longer having symptoms, they're less likely to keep seeing you because you're, doing well. And I think that leads a lot of people to get lost to follow up for a multitude of reasons, like I just mentioned. And for the same reason, it becomes harder and harder and harder for doctors who do research in this condition to enroll people because we're often not getting them fast enough or keeping them long enough. And because the headache could conceivably go away for 2 years and then come back, Sometimes, someone who has it may think, oh, geez, I guess maybe I don't need a doctor for this anymore. And then it comes roaring back, and then the whole process starts over again. So people get misdiagnosed a lot. The single most common misdiagnosis would be migraine. Sinusitis, I find that one a little shocking, but there it is. About 21% have been misdiagnosed as having sinusitis. And then sometimes allergies and dental issues. Again, I find those ones a little hard to swallow, but there it is. So there are some issues with why people get misdiagnosed that I think is really important for people to know as well. As I mentioned before, if someone is sensitive to light, that may lead someone down the wrong path and being led to a diagnosis of migraine, when sensitivity to light, particularly if it's in one eye, is allowed in cluster headache. Sometimes those autonomic symptoms that I described to you before, those can be mistaken as symptoms of sinus disease. And I think that's probably why that misdiagnosis happens a lot. And this one is really unfortunate. While we know that cluster headache does appear more often in men compared with women, unlike migraine, women may have attacks that are a little different than men. Sometimes they don't fit the mold just quite so perfectly. Maybe their attacks are just a little longer, or maybe they don't cycle quite the same way men do. And I think if a woman is coming in with a headache that doesn't quite fit into a nice little box, they're a lot more likely to receive an incorrect diagnosis and be labeled as migraine. And I've seen that countless times in my own practice. In fact, my very first patient I ever had when I finished my fellowship and started headache practice, she had cluster headache, and she was told that it was impossible for her to have cluster headache because she was a woman. So these sorts of beliefs and practices are really out there. And that's very unfortunate, because even if the ratio really is 3-to-1 men to women, there's still lots of women out there that have cluster headache, and we have to be open-minded. So the reasons why it can be misdiagnosis, there's not just the reasons I stated, there's also the word cluster in the diagnosis that can in itself be a little bit misleading. And one of the common incorrect terms that sometimes people see get labeled as having cluster migraines. Now, cluster migraines, that really it's sort of a descriptive term, but it's not a diagnosis. So what I think about when I hear someone saying they have cluster migraine is one of two things. It means either their doctor's not sure if they have cluster headache or if they have migraine, or they have migraine that tends to occur on back-to-back days that cluster together. Therefore, someone believes they may have cluster headache because they are clustering. And I think the term cluster headache is part of the reason for its own misdiagnosis for what it's worth. And then you have to keep in mind that while cluster headache is, it's not uncommon, but it's not super common, whereas migraine is incredibly common. And it's not impossible. In fact, it's not unlikely for someone to potentially have both problems. So there are definitely people who have an independent diagnosis of migraine and a diagnosis of cluster headache. And I think that if we have a history of someone who's had a previous diagnosis of migraine and then comes in with a new headache, the new headache may get overlooked or attributed to being migraine. And I do definitely see that more common in female patients compared with male patients. So pathophysiology means, why does it happen? What's the mechanism by way this headache is generated? And I think when it comes to many primary headache disorders like cluster headache, we don't know exactly. There is a lot of thoughts out there. We know that it may represent a spectrum of disease because there is 2 or 3 other related headache disorders that we differentiate based on the timing of the attack. So is it within that 15 to 180 minutes and does it meet criteria for cluster? If it's shorter and there's more headache attacks per day, that may be a completely separate diagnosis. And that can be important because it can mean that treatment of each diagnosis is a little bit different. But we do believe there is a little bit of overlap, and sometimes making sure that the timing of each headache attack is tracked properly can be really important at actually coming to the proper diagnosis. So we know that there are structures in the brain that light up a little bit when we actually image somebody when they're having a cluster headache attack. And we know that parts of the brain called the thalamus and the hypothalamus are probably related at generating this disorder. Exactly what they do and what's wrong is still to be determined. But there is some interplay between what we call the trigeminal nerve, which is responsible for the sensation of the face and the head on that side, as well as what we call the trigeminal cervical complex, which has to do with the nerves innervating the back of the head, as well as the nerves coming from the upper part of the neck, called the cervical spine. And we think that the interplay between all of those structures together forms what we call the trigeminal autonomic reflex. And that's why the pain and the autonomic symptoms tend to come together. So we mentioned that unlike migraine, it's not uncommon for us to find, something else that's going on that could be playing a part. Often that something else is nothing to worry about, but it may impact treatment. So for example, I put on here some that are very uncommon, but not impossible, things that we often go looking for. And we often go looking for those specifically if something doesn't fit. So if we hear, okay, you have cluster headache, but there's just something that's not right. Maybe the attacks are longer than they should be. Maybe they're shorter than they should be. Maybe it started later. Maybe it started in a different way than it should. Those cases, we may actually be more likely to go looking for these things. But there is some other things that we find even in people who fit the mold just perfectly. We have noticed that people with cluster headache are more likely to have an abnormality on their pituitary gland. And that abnormality can range anywhere from a small growth called an adenoma, which can secrete hormones or sometimes secrete nothing. And it may just be a small growth that never actually plays a part into your overall long-term health. So even if we find this, it doesn't mean it's going to be life-threatening or affect one's longevity or impact with other health problems. But sometimes if we do find one and it secretes hormones and we treat it, the headaches can actually get better. So that's an important reason why we sometimes go looking for it. And we especially do it when things don't fit or when our first line treatments don't seem to work. What we'll often do when we see someone who's coming in with a first diagnosis of cluster headache is, my practice, and granted every physician has a different practice, but I would argue that the research would support that most or if not all patients with cluster headache should have an MRI brain to take a look at the pituitary gland specifically. And sometimes just some baseline hormonal screening. So things like thyroid screening for testosterone, or screening for a hormone called prolactin can be helpful in that it may point us towards something else going on, or it may help us make treatment decisions. For what it's worth, we do sometimes also recommend a sleep study, and that can be for a few reasons. Number one, if someone does have sleep apnea, which is a condition of disordered breathing in sleep where people, they may gasp in their sleep, they may snore a lot, they may actually, be depriving themselves of oxygen because of this condition. And we know that untreated sleep apnea is also a risk factor for things like stroke and high blood pressure and coronary artery disease. But we also know that if we treat sleep apnea in a cluster headache patient, their headaches can get better. And interestingly enough, we have found that there's some people with what I call the episodic cluster headache who may only have symptoms of sleep apnea while their headaches are active, in that sort of perhaps in the fall or in the spring, but in other times of year, they don't seem to have sleep apnea. So even if we find it, it may only need to be treated when the headache is active and not at other times of the year, for what it's worth. But it can also be a reason why a sleep study may not give us a diagnosis of sleep apnea. So it's also important that if someone is getting it done, a proper sleep study should actually be done while the headache is active. So there are ways in which we treat, and there are different strategies that we employ for treatment. And Wendy, just give me a shout if I'm close to time, But we know that episodic cluster headache patients, there may be a couple of different types of treatments they need. So one thing we call is abortive or rescue treatment. So what do you do when the headache is happening to try to get rid of it and feel better? Then we have what's called transitional treatment. So transitional treatment is something you might take at the beginning of a cluster cycle with the aim of reducing the duration of the cluster cycle, reducing the overall number of headaches in that cluster cycle, or reducing the number of headaches per day during that cluster cycle. But it's not something you're on long-term in between cluster cycles. Whereas proper preventive therapy means, for example, if you have someone with chronic cluster headache, or if you have someone with really frequent cycles of cluster headache, those people may need to be on some kind of preventive medication year round. So some patients with cluster headache need one of these types of treatments. Some people need two. Some people need all three, depending on how bad things are. The problem we run into is because it's hard to enroll people for a lot of the reasons I stated. Sometimes it's hard to catch people at the beginning of their cluster headache cycle. Maybe neurologists don't get referred these people or get to see them until their cluster headache cycle is over with. So it can be hard to know when to enroll someone in a study. And even in some of the newer studies we have, if we're initiating a new medicine, they often have to do a screening first to see what their baseline is like. So there may be a couple of weeks at the beginning where we're getting a baseline screen before we introduce an intervention. So it's not really representative of starting a medicine right at the beginning of a cluster headache cycle. So even the way that our studies are designed are not perfect for what we do see in real life. So a couple of things we think about in terms of rescue treatment. And there's a couple of things that I want to make sure that everyone, either who has this or who treats people with it or who knows someone who has it, can maybe help them out with. And I think the most important thing to think about is oxygen. And what's interesting is it's what we call level A evidence, meaning it has the strongest evidence out there for its use, meaning we know it works. And it's important because upwards of 80% of all people with cluster headache will see a relief of their individual headache episode within 15 minutes of administration of oxygen. But here are the problems we see with oxygen. Sometimes oxygen is not delivered properly. Sometimes if someone goes to, let's say, the emergency room, they get oxygen put in their nose by what we call a nasal cannula. That is not sufficient. So we know that for oxygen to be delivered properly during a cluster headache cycle, it needs to be high flow oxygen, so at least 12 to 15 liters of oxygen per minute, and it needs to be delivered by a face mask. And if there are holes in the face mask, those holes should be filled. And a lot of those things are things that I sometimes have to troubleshoot with someone. If they come and see me and they say, hey, you know what, I've already had a trial of oxygen, it really doesn't help me. Sometimes one of those things was missing along the way. And there is even some more recent work to suggest that even higher levels of oxygen, even higher flow oxygen levels can be helpful for people who don't respond to lower levels. The other problem we run into is because, as I mentioned, lots of people who have these headache attacks, their individual headaches may be less than 60 minutes. In fact, many of them are. So introducing an oral medication is often not helpful, because to actually absorb a medicine through your stomach to then have it reach its peak concentration in your blood often takes upwards of an hour. So actually taking a medicine orally is often not the answer. So we have to think about other routes. So that's why sometimes we have to use intranasal formulations. So there is medicines called zolmitriptan and sumatriptan, which can be introduced into the nose, as well as sometimes lidocaine can be used for people who can't take sumatriptan or zolmitriptan for other medical reasons. And then we actually have injectable therapies. So sumatriptan actually comes at an injectable level, and it's been studied widely and shown to be very effective. But the problems we have here is it's not reasonable, cost-effective, or safe for people to take this, 8 times a day if they have very high-frequency cluster headache episodes. And I kind of mentioned a little bit about some of the issues with oxygen, but then there is some of the issues I haven't mentioned, like it's not always practical to cart around an oxygen tank with you, which kind of goes without saying. So, and then for some, depending on where people live and what insurers they're dealing with, it's often not covered. So there's often some out-of-pocket costs that come with hooking up oxygen that we don't often think about. And sometimes we're guilty of that as doctors, about not always thinking about these things. Then the transitional treatment, which I mentioned, these things are also imperfect, but they can really work. So sometimes we use oral steroid medications like prednisone or dexamethasone. And those can work at both shortening and decreasing the severity of the headache cycle of that cluster period. But, these medicines are not nothing. They are, they're part and parcel with their own side effects, with their own problems. And we have to be careful about, can we give this to the right person? Can we do it safely? Are we doing it too often? And we have to make sure we make these decisions with a patient as well. And then injections and infusions can be reserved, for people who just, don't have an effect from the standard oral medications. But interestingly, we have a procedural treatment that actually has really strong evidence. The problem with this again is, there's not every provider out there who can actually do these procedures. So sometimes it has to be done by a neurologist, sometimes by a pain clinic, sometimes family physicians actually know how to do this. Sometimes emergency room physicians know how to do this, but it is important that these get done with a local steroid medication. And we know that if they're done right at the beginning of the cluster headache cycle, they can actually be effective at reducing the overall frequency and duration of that cluster headache cycle. And as of very recently, and this is pretty exciting, because if we look at what's come out recently in terms of evidence-based treatments for cluster headache, there hasn't been a whole lot. But as of just very recently, a medication called Emgality has come out. Initially, it was studied and designed for migraine, but when it's dosed differently and delivered at the beginning of a cluster headache cycle, it also has had proven benefit for people with episodic cluster headache. And it has just been recently approved in Canada. And as of today, we're able to prescribe it and enroll people in the patient support program to help them actually have access to Emgality for cluster headache. So this is, I guess, a timely day to be talking about this. It is dosed differently than the migraine dose, if anyone here is familiar with it. And the way that it's dosed is at the very, very, very beginning of the cluster headache cycle, you're given 3 injections, and then that's continued every month until that cluster headache cycle subsides. So that's the way that we use it. There are a lot of other preventive treatments, so things that can be used year-round, either for people with really frequent cluster headache cycles or people with chronic cluster headache. But again, we lack a lot of evidence into what is helpful and what isn't. And a lot of the medicines that we use don't have a huge amount of evidence to support their use. It doesn't mean they won't work. Certainly speaking, I know lots of people who've had really good effects from all of these medicines, but it just means that there's a bit less certainty, and often the medicines are a little messier compared with some other treatments. If you look here, none of these medicines were designed for cluster headache. Doesn't mean they won't work, but there is also some other exciting stuff coming out. There is a treatment called non-invasive vagus nerve stimulation, which is something, we briefly had it available in Canada, but it's going to be available again very shortly, I believe. And it is something that can deliver pulses to the neck, and you can do it when someone has episodic cluster headache. It's actually been shown to help reduce the burden of headache in about half of patients. So the good news about it is it's well tolerated. Very few side effects are associated with it. So it may be a really good choice for people who have a hard time with medicine or are prone to side effects of medication, or maybe they have medical problems that prohibit them from using some other medications. Then there is some, kind of scary sounding surgical options that we really don't employ very often, either because the benefit of them does not seem to be worth the risk, or they're not available widely, or they're not available anymore, or there's no one to do them. So there is a few things that are emerging that I'm sure anybody who's read about cluster headache or is dealing with cluster headache has certainly thought about or read about and is wondering about. And the most common thing you'll hear about if you read about upcoming treatments in cluster headache is psychedelic substances, and specifically psilocybin-containing mushrooms. The jury is still out as to whether these are truly effective or not, but and we always have to be very careful when we interpret data that we get from just surveying people, because it's imperfect. Of course, we need to do proper trials to know whether or not these are effective. But for what it's worth, there is some good anecdotal data. At least anecdotal just means data taken from people who have been dealing with this problem, that using these psilocybin mushrooms in what we call microdosing. So that would mean dosing below the level of giving you a hallucinogenic property, can actually be effective for some people. This is nowhere near ready to be prescribed by doctors yet, but there is some trials that are ongoing throughout the world. And hey, if it, I hope that it helps, and I hope that the trials are positive to give us just one more option that we can give to people. And there is, there is a support group for anyone who, I'm sure anyone who's attending this who hasn't has heard of the Cluster Buster support group, and there is advice and data on this type of treatment on their website for what it's worth. The other thing I think that's important to mention is that we do see a higher level of substance abuse in people who have cluster headache compared with the general population. Whether that has to do with cause or effect or coping with a really terrible illness, I just don't think we know. But I do think it's an important thing that everyone who treats and everyone who knows someone with cluster headache is aware of. And I think it also points out that we probably need to do better at just finding more treatments. I think that's a pretty important thing to talk about. So here's what I think everybody should really know about and ask for if and when they think they have this, or they're talking to their doctor, or they know they have it and they're seeking out treatment. So recognize that things can be cyclical. So keep your appointment. Even if you're feeling better, by the time you get the appointment, keep it. Take note of how long your individual attacks for. They can be terrible, but time them. Time them even with your phone. And then time how often they happen. Time them how many times per day, because that can be really paramount at coming to the correct diagnosis, because that actually really can. And I didn't talk about the details of some of the related disorders, but some of them really are treated quite differently. And then note the time of day, not just how often they happen and how long they are, but note if there's a very specific time of day that they happen, because that actually can be really helpful for people like me at coming to the right diagnosis. And if you don't know what you look like in the mirror when it happens, or you feel too unwell to really pay attention, take a photo. Take a photo specifically of both of your eyes during an attack of this headache. And that can allow your doctor to see, hey, look, there is something observable there, because the chances are, just by random chance, that your doctor probably will not have the opportunity to witness one of these headaches while you're in the office. So either a video or a picture of your eyes during a headache attack can be really, really helpful for people who are trying to help. So there are lots of people who may not have, or they may have knowledge of it, but they may not have knowledge of what and how to treat cluster headache with. So ideally, if this is you, or if this is someone you care about, try to get them someone, and I would say most neurologists, for example, would have at least the basic skills in managing and diagnosing cluster headache. And it's important to advocate for, even if you're feeling better between attacks, to have somebody whose roster you can stay on for when you need help. So I think that if you contrast this to migraine, if people have what we call episodic migraine, and it's under good control, it's perfectly reasonable for a neurologist to say, hey, you have the skills you need, your family doctor has some good skills, and you can give them advice and discharge them back to their family doctor. That's a pretty reasonable practice. With cluster headache being a lot less frequent, a lot more infrequent, a lot more challenging to treat and diagnose, I do think most of the time it requires the skills of a neurologist to treat properly over the long term. And keep in mind that these disorders are wrought with suicidal thoughts and substance abuse. So if you or anyone you know is dealing with this, please ask for help, because there is help available for this too. Okay. That's about all I have. This was just an overview of a very complicated problem that I hope you guys all were interested in hearing about.
Thank you very much, Dr. Kingston. And thanks again, everybody, for joining in tonight. I hope you all stay well in this crazy COVID world that we're living in. Thank you again to you, Dr. Kingston, for joining us. And we'll be in touch. Check our website out regularly. We are trying to hold one webinar per month. So we have another one coming up on February 22nd on the female life cycle and migraine with Dr. Rose Giamarco. So hopefully you'll all be able to join in on that as well. And I wish you a happy evening. Take care.
Thank you, everybody.
Bye.